is a very renowned psychiatrist involved with the mental health policies of the state, and he holds the position of Medical Director, Child Psychiatry, New York Child Care Center. His topic today of discussion will be theories and principles of management of conduct disorder. Very special topic. Thank you, Dr. Rahman. Thank you.
Credits go to our, especially in this session, to our CME team, Dr. Fadul Yusuf, Dr. Muhammad Akhtar Hassan, Dr. Khanis Banu Nilufar Himi. Today, we know that in CME we cannot go in detail. I will not take much time. But the topic that I'm going to discuss is so important for every parents or brothers or sister, whoever see or saw any child. That is, so I'm going to discuss about the child behavior, very brief because it is very extensive, explorative. Before I discuss, my name is Qazi Rahman. Shafjol is my nickname, actually given in my medical college. I am from Dhaka Medical College. That is my pride for my whole life. Okay, so what we are going to discuss? Conduct disorder. I will try to go very simple because many psychological jargons are there that may irritate you. So first thing, what is conduct disorder? First thing, we know that some kids sometimes they don't listen to you. They don't listen to the parents. Okay, if you ask the child, okay, now no more, okay, you are surfing the phone too much. It's time to go to bed. But he or she is saying, no, I want to play more, I want to play more. Okay, get out of bed, it is school time. No, I want to sleep more. So there is simple oppositional behaviors. So there is huge difference between oppositional behaviors and conduct behaviors. So most of our doctors has understanding that oppositional behavior, conduct behaviors are almost same. They don't listen, they are bad kids. So, but oppositional behavior is very common. Actually most common in child psychiatry. Okay, they don't listen that much, they're easily irritable, they make people easily annoyed, don't want to follow the rules in the school. So remember, those behaviors, if are present at home and also in school or any other setting, then it is important. If it is present only at home, not in school, so there is some problem at home, not with the child. So just for simplicity, oppositional behaviors and conduct disorders are not same. Many people think that oppositional behaviors, if it goes to severe range, then it is conduct disorder. No. Oppositional behaviors is simple, conduct disorder is serious. Say conduct disorder, if you want to remember, so next is diagnosis-wise. So you don't need to go so details, psychological jargons. Conduct disorder, say major 4 things. If the behavior is beyond the range, like destruction of properties, very important. He breaks computer, hits people. This is not opposition, destruction of real properties. Second, if there is serious social deceptive behaviors, like stealing, robbery, assault, and cruelty to animals, and there is legal problem. So destruction of property, destruction of destructive behaviors toward human or animals, setting for cruelty to other things. If those things together and legal systems, gang involvement, then it is conduct disorder. Okay. That should not be in only few days. That is, it may be childhood onset type if it is less than 10 years. If it is more than 10 years or so, there is big difference. Okay, other subtypes, very simple. Affective aggression or proactive aggression. So we are now, I am not discussing about oppositional behaviors because so that's simple, that the huge lecture. I am now in serious behavioral problem, conduct disorder. You can say delinquent behaviors. Antisocial personality disorder will be named the same case after age 18. So below age 18, we say a conduct disorder. We don't want to label the kid as antisocial, sociopath. No. So we want to still give a name, conduct disorder. After 18, the same kid, same symptoms and signs will be assigned as antisocial personality disorder. Totally different treatment, different modality of social aspect. So now we are in a very wide range of worldwide phenomena, aggression. So aggression may be affective aggression. When aggression is associated with some emotion like anger, intense muscle spasm, restlessness, increased blood pressure, increased pulse, and with emotion, crying or screaming emotion. Some aggression, no emotion, nothing, quiet, cool, very good, but he kills people, set fire. That is more dangerous, right? So one is affective aggression, one is proactive, active aggression. So these are very simple and others are overt and covert. So it's self-explanatory. I will not go that detail, then it will take much time. Now, simple thing, I'd say 2 to 10%, median is 4%. But say, if we must differentiate between oppositional different disorder and conduct disorder. Oppositional different disorder is very common, 15 to 25%. My son, he is now engineer. He was oppositional. Oh, Dad, I will not go to school. Who goes to school? Stupid people goes to school. I am not going to school. I am not dumb. You are made, you doctor, you put glue in your back and reading, studying. Who becomes doctor? I don't want to put glue in my back. And ultimately, he ended up in one of the best engineering school in the USA, and he's now doing a very good job being an engineer. So that was oppositional behaviors. But now I'm asking aggressive behavior. He was not aggressive. He was not killing cat. One of my patients, he put one small kitten inside the microwave and turned the microwave on. Another kid, I will not go in detail. He put pencil in the rectum of this small kid and put in stove. So when mother came and said the kitten is dead, after 2 days, she discovered that it was done by him. So there is a big difference, both pathophysiologically and manifestation. So manifestation, externalized behavior, internalized behavior. So if we say externalized behavior, hyper, irritable, angry, externalized behavior. Internalized behavior cannot hyper, but inside is dangerous. That is called social conduct. Okay, now, so usually male are predominant, the independent. One important thing, we think that, okay, this special race, this is different color, they are aggressive. No. Actual conduct disorder is, there is no significant racial difference. Yes, there is economic difference. So economic difference, social structure, that is totally different. Economic difference in this country and every country was imposed by the society, not by the kids. So we should not have any negative impact from the kid or towards the kid. The impression, okay, they are bad, they are this color, they are this race, they will be aggressive. No. They are made to be aggressive due to some reasons. There we will go. Okay, now, what are the predictors? So, that will life experience and interactions of different factors. Himi, you tell me, you give me some sign when I should. How much time you have?
Continue.
Okay, now, so how, if I go to incident premium, it will be huge. Now, we should know principle, how it develops. Now, there are many models. So, most important model is additive models. I will go there. One, say, principles of equifinality, principles of multifinality. That is simple thing. If multiple factors lead to one manifestation of one disease, that is called equifinality. If one factor or multiple factors but lead to different diagnoses, many diagnoses, then it is called multifinality. So in this case, the equifinality towards aggression is more dangerous. Okay. Now, interactive model, that is some principles and other principles interact each other, leading to development of external behavior, that is called interactive models. Now, principles of multifinality, I told you, okay, this is typical to our psychiatry. Anybody psychiatric resident or doctor, they know that is social factors. So, if we just think about biological factors, some factors automatically will come. Genetic, medical, substance, some diseases, infection, inflammation. As our Dr. Alia Safsar used to see the etiology of the disease, genetic, tumor, inflammation, miscellaneous, the biological factors. Psychological factors, just remember, any trauma, rejection, isolation, psychological factor. Social factors, poverty, lack of job, or lack of friends, lack of family, social factors. All factors together must work on as comorbidities to develop a psychiatric problem. Okay. That is general for everybody. Now come biological predisposition. Now, biological predisposition in conduct disorder. Most important, males are more aggressive than females. Why? Some genetic factors account for moderate amounts of variance. MAO-A gene in X called warrior gene. It is a single gene theory. It's not established. Don't take it like that somebody has MAO-A gene. But when it is present in boy, and if they suffer from other stresses, then that boy or girl may develop conduct disorder. Now, mostly it is polygenic factor and hereditary factor is there also. So, as like schizophrenia, bipolar disorder, conduct disorder, actually exact pinpoint is impossible. Okay. Now, so that was biological factors. Now, I'm the socio-cultural factors, community level factors, family level factors, social context. We will go. So, say community level, say poverty, ethnic heterogeneity, high. So, if 6 months I am in one district, another 1 year in another district, before the child can identify with other kids in the school or society, they got transferred to another place. How much? 2 minutes. Oh my God. Okay. This is most important. Early life experience. That if we understand this, then we will understand the whole thing. Like, this is called Patterson's 4 steps didactic chain. If parents, all of us, most of us, we have kids. See, if kids for some reason they want to scream, temper tantrum, parents want to suppress them. Okay, don't scream, don't cry, stop it. If the kid is small, below age 12, he being scared, he will listen. But how long? Up to age 12. Up to age 12, in some way, he will listen to you. Okay, either being suppressive. But after 12, in the meantime, he will understand that, okay, when my father screams, if I also scream him back, I also go temper tantrum. Or if I throw some punches to him, he comes down. He no longer is, or if I threat him that I will call 911, then parents come down. So this kid is getting a behavioral pattern, how to express his aggression without knowing the right behavior. So before age 12, most important treatment modality will be parental management training. It will not work after age 12. So parents, if any kids has some problem, whatever is the problem, call any child psychiatrist or child psychologist, not necessarily me. So go and ask. Don't think that we are doctors. We are chief of critical pulmonology, we are chief of cardiology. Yes, you are specialist in your own field. But if you really want that this child will develop the good behavior in his own manifestation, in his own capacity, please just go and ask what to do. Very easy. Before the dangerous behaviors like conduct disorder develop, it should be in the level of oppositional defiant disorder, which is easy to fix by doing parental management training. So I know there are many theories. Dr. Yusuf Bhai is saying that I don't have that much time, but if I don't say this thing, I will feel bad that nothing I told you. If some child behaves bad, don't go in tug of war. Oh, I told you to go to bed at 10, you are not going. So take out your computer, take out your phone. So you are grounded. This child will develop more defined behavior. Go towards him. Okay, my son, okay, today you are not feeling that well, or maybe maybe you are hungry. See, you are distracting, you are aligning with him. You are not doing tug of war. Okay, you bad, I am good. I am parent, I must tell you, you must listen. No, go towards him. My son, nearby. My son, probably you are not feeling well. Your stomach is okay. Did you sleep last night? Or are you hungry? Hey, okay, can I bring some food? Oh, let's watch some TV. Okay, some video game. Then, make some story. Hey, I have my one friend who lives in California. Oh my God, his son, he has a son exactly of your age. He is my best friend. He has a son. Oh my God. Most of the children, most of the parents do the mistake that, oh, my friend's son got Stuyvesant, got Harvard, got this. I want you to do this. No. Always compare in a different way. Oh, my son, you know, my friend's son, oh, he doesn't listen at all. You listen to me. Now, this time forget it. Yesterday you listened to me. You are so great. That my friend's son, he hits people, he kills people. But you are my son. Today you are not feeling well. So let's go, forget it. If you give some therapy, this is called therapeutic alliance, this child will never be against you. He understands that he is behaving bad. But when he sees that my father is toward, why child is more identified with mother? Because mother has that instinct. Father has some kind of instinct, which, okay, 1 minute, which is male instinct, we should not. So I know this conduct disorder, it's a very serious thing. Or that means aggression is throughout. Some aggression may be compulsive due to some psychiatric disease like schizophrenia. Those schizophrenic patients are not very violent. Schizophrenia, genetic disease, bipolar disease, and substance. But oppositional different disorder, those are not due to that. So if any problem for behavioral issues of the child, please talk to the teacher, talk to a child psychologist, child psychiatrist. Start from the beginning, and it is very actually manageable. Most of the parents, they go late. At that time, after age 12, the parental management training will not work. At that time, so many different ways, which is very different, multi-systemic therapy, school, church, residential treatment facility, residential treatment center, group home. Those things are big theory, but they do not work. Any child putting in residential facility, group home, do you think he will do better than the child in your home? No way. But at some point, parents having no other alternative, they put their kids in residential facility. Where they will put? Ultimately, the child will develop more and more antisocial behavior. And this is the psychological management, but there are medical management. I am not going, I am finishing in 30 seconds. Medical management is mainly done through some medications. None is FDA approved. Depakote, Risperdal, Zyprexa, whatever psychiatrist will. But having no other alternative, the child is killing people, the child is killing cats, the child is setting fire. What to do? So, best management is to talk to Dr. Rahman. Thank you.
Okay, thank you.
If you kindly put the slides up, I can talk from there, that'll be fine. But talk to discuss from person to person by respiratory droplets. So let's talk about the pathophysiology of COVID-19 virus. This is a virus that attaches to host with ACE2 receptor with the spike protein, and that can create some of the pathophysiology, creating the disease manifestation. It can cause direct cytotoxic effect, causing cell death. It also causes dysregulation of renin-angiotensin system, resulting in tissue injury, inflammation, vasoconstriction, and vascular permeability. It also causes endothelial cell damage, resulting in thromboembolic phenomena. It causes dysregulation of our immune system, resulting in cytokine release syndrome. The ACE2 receptor is also located in various organs in our body.
Is there any nerve damage prospective of the GI?
No, we don't have any long-term follow-up data in patients who had COVID and GI. Most of the people, such as inflammatory bowel disease patients, they got better after the infection.
Any particular treatment for that?
Particular treatment for which one? The COVID, or are you talking the GI symptom?
The GI symptom post-COVID.
No, most of the GI symptoms went away after the COVID was treated. So everybody has a different recovery time. People who has high lipase, they became normalized after the COVID was treated. People with a high elevated liver enzymes, they became normalized after the COVID was treated. So there's a multifactorial things that can cause elevation of the lipase and liver enzymes. But most of them, they came back to normal. The people with pre-existing liver disease, they never become normal because they have an existing liver disease, so they continue to have the same problem.
Mostly as to the highest level. So this is Dr. Muhammad Kamrul Islam.
Thank you, Sajal Bhai and Dr. Qazi Rahman. I also want to introduce myself as I'm an attending neurologist, faculty Mount Sinai, working in Queen's Hospital Center, and a board certified neurologist. Today we're going to discuss about one of the more common causes of dementia, which is Alzheimer's disease, and the third common cause of dementia, Lewy body disease. I have a lot of slides, so and time is short, so we'll just start immediately. So, Alzheimer's disease is the most common cause of dementia and one of the most leading causes of morbidity and mortality in the aging population. And the hallmark neuropathological changes of Alzheimer's disease are diffuse and neuritic plaques, marked by extracellular amyloid beta deposition, and neurofibrillary tangles. As you can see here on the left side is the shrunken brain, and this is what happens. You can see the dying neuron with tangles, plaques, and below there you can see the healthy neurons. Pathogenesis, well, the pathogenesis of Alzheimer's disease remain unclear. All forms of Alzheimer's disease appear to show overproduction or decreased clearance of amyloid beta peptides. And a definite diagnosis requires histopathology examination, but most epidemiological studies of Alzheimer's disease rely on clinical criteria. So, and approximately 1/3 of the individuals over the age of 85 years who die without antemortem diagnosis have pathological consistent with Alzheimer's disease. As you can see here, again on the left side is the normal neuron. There's the astrocyte and microglial cells. On the right side, you can see how severe the atrophy is. It's all shrunk, the sulcuses and the gyruses. And the formation of neurofibrillary tangles, amyloid beta plaques, dystrophic neurites in the neuron, and see what's going on with the astrocyte and microglial cells. All are damaged. Incidence and prevalence is AD is increasingly prevalent with the advancing age, and overall burden of AD is substantial worldwide. In the United States in 2011, there were an estimated 4.5 million individuals over the age of 65 living with clinical AD. And this included 0.7 million people aged 65 to 74 years. And there is a long pre-symptomatic period between the onset of biochemical changes in the brain and the development of clinical symptoms, suggesting that long-term epidemiological studies beginning at an early age are needed to properly study the gene, lifestyle, environmental determinants of amyloid vascular disease. There are two types, the early onset and late onset. So that early onset is the genetic type, accounts for less than 1% of the cases. It follows an autosomal dominant inheritance pattern related to mutations in genes that alter amyloid beta protein production, aggregation, or clearance, including amyloid precursor protein APP, presenilin-1 and presenilin-2. Late onset mostly happens over the age of 65 years, but again, there are carriers of one E4 allele, and at 2 to 3-fold increase odds of developing Alzheimer's disease with this allele, compared with non-carriers, and those with 2 E4 alleles are at 8 to 12-fold increase. As you can see here, 30 to 60 years, these are early onset, only about 1%. Then there is less than 65 years, which is about 4%, kind of close to 4%. More than 65 is 95%. Genetic risk factors. Family history of dementia is a risk factor for Alzheimer's disease. We already know that most of the cases are up to only before between 30 to 60 years. Here you can see the parents there, father, mother, and there's the sibling. Acquired risk factors: hypertension, smoking and diabetes, dyslipidemia, cerebrovascular disease, and peripheral atherosclerosis. I want to say a little bit about cerebrovascular disease. This and AD frequently coexist, and the co-occurrence of Alzheimer's disease and vascular pathology is often referred to as mixed dementia. Peripheral atherosclerosis, markers of peripheral atherosclerosis disease burden including measures of carotid intima media thickness and coronary arteries calcification. Type 2 diabetes and obesity. Obesity and type 2 diabetes have been associated with approximately 1.5 times increased risk of Alzheimer's disease, as with other vascular risk factors. Lifestyle and activity, again, physically active individuals have lower incidence. Prevalence of cognitive decline in dementia, including Alzheimer's disease. Brain trauma, another risk factors. So history of severe brain trauma with loss of consciousness of 30 minutes or more have been inconsistently associated with Alzheimer's disease, increased risk. Genetics, I'm going to go very quickly because there are a lot of information in here. AD is most common form of dementia with estimated lifetime risk of nearly 1 in 5 for women and 1 in 10 for men. So men have more chances to develop it. The genetic basis of AD is best understood in the early onset form, which accounts for less than 1% of the cases, and typically follows an autosomal dominant, we already said. Families with autosomal dominant AD are those with 3 affected individuals in 2 or more generations, with 2 of the individuals being first-degree relatives of the third. In these families, the affected individuals typically develop symptoms between 30 and 60 years. There is mutation in 3 genes, APP gene, presenilin-1 and presenilin-2. And the presenilin-1 is located in chromosome 14q, presenilin-2 is located in chromosome 1q. Trisomy 21 Down syndrome is another risk factor for Alzheimer's disease. Here is again the risky genes on the left side, normal brain on the left side, lower in the lower slide, and Alzheimer's disease on the right side. Late onset Alzheimer's disease, more than around 95% of the patients with Alzheimer's disease are late onset, so over 65. The genetic basis of late onset Alzheimer's disease is more complex, with susceptibility conferred by a variety of more common but less penetrant genetic factors, likely interacting with environmental and epigenetic influences. Today, the most firmly established genetic risk factor for late onset AD is apolipoprotein E, or epsilon 4, and is located in chromosome 19. Genetic testing, commercially available for each of these early onset autosomal form. Testing can be done in symptomatic or predictive patients, pre-symptomatic individuals with low mutation in their family. However, testing is not widely adopted because of current lack of highly effective preventive or therapeutic strategies. So, routinely, do we do it? We don't. Clinical features, introduction. AD is a neurodegenerative disorder of uncertain cause and pathogenesis that primarily affects older adults and is the most common cause of dementia. While treatments are available that can ameliorate some symptoms of the illness, there is no cure of the disease so far. At the end of my discussion, I will discuss that recently, 3 days back, a new FDA-approved medication has come out. There is no cure of the disease. The currently available, and this disease inevitably progresses in all patients. So again, you see on the left side is the normal brain, right side, severe Alzheimer's disease. Age of onset, it's a disease of older age. The higher the age, the more the risk. It is exceptional for Alzheimer's disease to occur before age 60. We already said that. Incidence and prevalence of AD increases exponentially with age, essentially doubling in prevalence every 5 years after the age of 65. Early onset AD is usually before 65 and presents with atypical symptoms, including language, visual, or mood or behavioral changes. So those are not the usual features. Those are early onset type Alzheimer's disease features. Cardinal symptoms, memory impairment, the most common initial symptoms of AD. Executive dysfunction and visuospatial impairment are often present relatively early, while deficits in language and behavioral symptoms often manifest later in the disease. So we're not going to go detailed in this, but I'll try to remember that declarative episodic memory is affected. This type of memory depends heavily on hippocampus. By contrast, subcortical systems such as like a brainstem and other subcortical area, procedural memory and motor learning are relatively spared until late in the disease. Memory for facts such as vocabulary and concepts, semantic memory, often becomes impaired later and is supported by neocortical temporal regions, particularly in the anterior temporal lobe. Within episodic memory, there is a distinction between immediate recall and late recall. Memory of recent events served by the hippocampus, entorhinal cortex, and related structures in the medial temporal lobe is permanently impaired early. By contrast, immediate memory encoded in the sensory association and prefrontal cortex is spared early in the disease, as are memories that are consolidated for long periods of time, years. And you can see here, sensory, short-term, long-term memory, declarative and procedural, there's a difference there. Executive function and judgment problem solving. In early stages of AD, impairment of executive function may range from subtle to prominent. So what is happening? Family members and co-workers may find that the patient is less organized, less motivated, multi-asking, like asking the same question repeatedly. Inability to complete tasks emerges, reduced insight into deficits, anosognosia, is a common but variable feature of Alzheimer's disease. It's common for patients to underestimate their deficits and offer alibis or explanations for them when they are pointed out. Loss of insight increases over time, and those with relatively preserved insight are more likely to be depressed. Those with more impaired insight are likely to be agitated, disinhibited, and exhibit psychotic features. Lack of insight may also impact safety, as patients may attempt to take on tasks they no longer have the capacity to perform effectively, such as driving. As you can see, it's again a complex part, but on the right side, you see the prefrontal cortex is working memory, amygdala is emotional memory, striatum or putamen is procedural memory, cerebellum is procedural memory, and medial temporal lobe. So we can see here, in addition to temporal lobe and the parietal lobes, the cerebellum and the putamen, other parts which are subcortical areas, are also involved with memory. Here, what's happening with this lady, as you can see, she has a phone bill which is overdue. Her flowers are dying, and she does not remember the date on the calendar. Again, on the left side is a normal neuron. Here is the Alzheimer's neuron, cortical shrinkage, neurofibrillary tangles, amyloid plaques, severely enlarged ventricles. Behavioral and psychological symptoms, neuropsychiatric symptoms are common in AD, particularly in the middle and late course of the disease. They can begin with relatively subtle symptoms including apathy, social disengagement, and irritability, to more problematic symptoms of agitation, aggression, wandering, and psychosis. Wandering is very common. They get up in the middle of the night, they just go out, and they disappear. Other signs and symptoms, dyspraxia or difficulty performing learned motor tasks usually occurs later in the disease. Clinical dyspraxia leads to progressive difficulty, first with complex multitask motor activities, then with dressing, using utensils to eat, and other self-care tasks. Sleep disturbances, they spend more time in bed. Seizures are very important. A lot of Alzheimer's disease, about 20%, 10 to 20%, they come with seizures in the later stage of the disease. Motor signs, pyramidal, extrapyramidal, motor signs, myoclonus are typically late-stage findings. Posterior cortical atrophy manifests with progressive cortical visual impairment with difficulty reading and driving. Mixed dementia, it is common for AD pathology to coexist with other processes such as frontotemporal dementia and Lewy body disease. Clinical course, it will progress inexorably. Doesn't matter what, the progress of the disease can be measured by mini-mental score status examination. So we have to remember here that the mini-mental stat exam, it drops to 3 to 3.5 on the average on each year, with a minority less than 10% having a more rapidly progressive course, about 5 to 6 points on the annual. The Montreal Cognitive Assessment Test is the preferred brief assessment tool, but we are still doing mini-mental mostly in our private practice and in the hospital. We still, a lot of us are not using the Montreal. An older age of onset of AD, more than 80 years, may be associated with a slower rate of decline compared with the younger patients. Conversely, early neuropsychiatric symptoms including psychosis, agitation, aggression have been associated with more rapid decline. The average life expectancy after a diagnosis of AD have been reported between 8 and 10 years, but may range from 3 to 20 years. Survival also relates to the age of onset. The symptoms being shorter at early age of diagnosis than late age of diagnosis. Patients generally succumb to terminal stage. As you can see here, on the left side, duration is 7 years. Then duration 2 years, Alzheimer's disease. As you can see, the part which is red are the good part of the brain, and the blue part of the brain is the damaged brain. Duration more than 2 years, Alzheimer's disease, and then duration 3 years. More than 3 years, you see almost a lot of the brain has been involved. Neuropsychiatric testing to establish a baseline to order to follow the patient over time to help differentiate among the different forms of neurodegenerative dementias such as Alzheimer's disease, Lewy body disease, FTD, frontotemporal dementia. To assess competencies and guide recommendations pertaining to driving, financial decisions, and need for increasing supervision. Neuroimaging. Now, does neuroimaging in practical life, do they always show the changes of Alzheimer's disease? Not really. Most of the patients in our clinical practice come with completely normal brain imaging. So structural MRI findings in both generalized and focal atrophy as well as multiple white matter lesions are most characteristic focal findings in AD, and there is reduced hippocampal volume or medial temporal atrophy. Other imaging, FDG PET is the most useful in distinguishing Alzheimer's disease from FDB in patients. Do we do that all the time? No, because it's expensive, not really practical, but we do that sometimes to differentiate between other forms of dementia. US Food and Drug Administration approval specifies that an amyloid PET scan that is negative decreases the likelihood that a patient with dementia has AD. So here you can see that on the right side you can see the purple, and going up as it gets worse and worse, the color is red. So on the left side, high normal cognition, second one, average normal. You see the purple is more purple. Low normal, and see the less and less purple, and you go to the right side, it's more red. Purple is almost going away. Clinical assessment, lower biomarkers. There's several widely investigated biomarkers for molecular and degenerative process, but not yet recommended. So these are low CSF, increased CSF, other laboratory testing routinely not done, but these are helpful tests. Diagnosis. Definitive absence AD requires histopathological examination. We know that. Probable AD is a syndrome of dementia defined by the following characteristics: interference with the ability to function at work, a decline from previous level of functioning, not explained by delirium or major psychiatric disorder, cognitive impairment established by history taking from the patient and a knowledgeable informant, and objective bedside mental status exam or neuropsychiatric psychological testing. Cognitive impairment involving a minimum of 2 of the following domains: impaired ability to acquire and remember new information, impaired reasoning and handling of complex tasks, poor judgment. More or less the same thing, include impaired language function, changes in behavior, other poor clinical criteria, clear-cut history of worsening. Initial and most prominent cognitive deficits are the following: amnestic presentations will include impairment learning and recall of recently learned information. And the non-amnestic type include either a language presentation with prominent word finding deficits, a visual spatial presentation with visual cognitive deficit, or a dysexecutive presentation with prominent impairment of reasoning, judgment, and problem solving. As you can see here, the 10 warning signs. Number 1, memory loss. Number 2, difficulty performing tests. 3, you see how he wrote, I don't remember. 4, disorientation to time and place. 5, poor or decreased judgment. 6, now they cannot keep tracks of things. 7, misplacing things. 8, changes in mood and behavior. 9, look at this. The gentleman is driving in a red light thinking it's green. Number 10, withdrawal from work and social activities. MCI due to Alzheimer's. We all need to know what MCI is. It is the initial part of Alzheimer's disease. There are 2 different types. There is a concern regarding cognition reported by patient or informant. Sorry. What happened? And objective evidence of impairment in 1 or more cognitive domains that is not explained by age or education. Here is a very good slide. As you can see, in the preclinical state, is a silent phase, brain changes without measurable symptoms, individual memories changes but not detectable on test, a stage where the patient knows but the doctor doesn't. MCI, here I think primary care physicians, PCPs, they start recognizing that there's some problem going on in here and we should send the patient to the neurologist. Cognitive changes are of concern to individual and our family. 1 or more cognitive domains remain significantly. Preserved activities of daily living. Mild, moderate, severe dementia, as you can see, is getting worse. Differential types is vascular dementia, diffuse Lewy body disease, which we'll be discussing. Vascular dementia is a different type of dementia, is the second cause, but is more stepwise fashion, not like Alzheimer's disease. FTD is a neuropathological and clinical heterogeneous disorder. It's a terrible, terrible disease to happen. They die within 5 years, and the behavioral changes, they come almost within 1 to 2 years, and the difference between FTD and AD becomes obvious. Treatment. Cholinesterase inhibitors, we all know, donepezil, rivastigmine, and galantamine. So cholinesterase inhibitors are used, which inhibits the acetylcholinesterase enzymes. The memantine is different. Memantine or Namenda is used, but not initially. Namenda, it benefits in patients with moderate to severe Alzheimer's disease. These works on NMDA receptors, and basically it's an anti-glutamic acid antagonist. It's a glutamic acid antagonist. Glutamic acid is an excitatory neurotransmitter which is necessary for the brain, but too much glutamic acid destroys the brain. So we initially start with donepezil, galantamine, or rivastigmine, and then when the disease progresses, we add Namenda. Okay, vitamin E, behavioral disturbance, nutrition, cognitive relation, exercise programs, these are just supportive. Okay, we're not going to discuss this. So that's Alzheimer's disease. We're going to discuss Lewy body disease. Okay, dementia with Lewy bodies. Dementia with Lewy body is a clinical syndrome characterized by fluctuating cognitive impairment, dysautonomia, sleep disorders, hallucinations, and Parkinsonism, and neuroleptic sensitivity. It is recognized as one of the most common cause of dementia after AD and vascular dementia. Gross pathology. DLB is associated with non-specific gross pathological changes of the brain that overlaps with other neurodegenerative disease such as Alzheimer's disease and Parkinson's disease. The cortical atrophy is less marked than Alzheimer's disease but follows a similar pattern involving frontal, temporal, and parietal lobes with relatively sparing of the occipital lobe. Microscopic pathology hallmarks the Lewy bodies and Levy nitrites throughout the cortex as well as brainstem nuclei, limbic structure best identified with aid of alpha-synuclein.
Very practical. So
I just have two things to, I have finished the main course, so two things to say. First of all, the new medication that has come up for Alzheimer's disease 3 days back, Aduhelm, A-D-U-H-E-L-M. Aduhelm, this is a monoclonal antibody. So like we use, I'm sure the Dr. Mujibur Rahman and our other pulmonary friends and oncology friends, infectious disease probably. So we use it, we will use it. So it's IV, it targets the beta amyloid and it will attach the beta amyloid and destroy them. When do we use it? Early Alzheimer's disease, which is MCI, mild cognitive impairment. I personally have not started, but I will start it. And the other thing I want to say, sadly, my mom passed away with Lewy body disease. Thank you.
We have some questions, Dr. Pano. So how, see, age-appropriate cognitive impairment, which you can say mild, MCI, right? Age-appropriate cognitive impairment, sometimes we say senile. How to differentiate from early onset Alzheimer's?
Right. Actually, age-appropriate dementia is not MCI. So
Cognitive
you will know.
ACI, age-appropriate cognitive impairment.
Cognitive impairment. So basically, we do what I do even now, even as they're suggesting to do the Montreal assessment thing. I'm still doing the mini-mental, the bedside, which is very good if you really do it. Okay. If they get less than 20, like if it's 21 to 30, it's mild. If they get more than 21, it's probably MCI. But if they get anything between 28, 29 or 30, it's probably not MCI, probably just age-related. They should get 30 over 30, okay? Sometimes they do not get it because of a lot of our patients are not educated. If you see the mini-mental, a lot of them are like they have to read English, you have to like close your eyes, that thing, you have to do that. And a lot of them did not go to school, not even first grade. So even if they're in their own language, like Bengali or other languages, Hindi or if you take the interview, you will see that they cannot do it. So that's why they can get 28 out of 30, but that doesn't mean that these are not age-related. So whenever you suspect that's what's going on, then you would suspect that it could be non-age-related MCI. Now, if everything is good, 30 over 30, but there's something still going on, and the patient, you feel that the patient is still, might be having dementia, then you get neuropsychiatric evaluation, like a neuropsychiatrists who are like neuropsychologists, who are not MDs, they're PhD. Yeah. So we send them for the neuropsychological testing, and then those testing can become abnormal.
And my last question, very important. Now, that was the grand round by Dr. Goldstein from Mount Sinai. There is, he got Nobel Prize due to just his most famous work was on dentate nucleus and exercise. So if somebody do exercise, at least brisk walking, 3 times in a week exercise, there is less degeneration from dentate nucleus, leading to less impairment or prevention in. Is it a fact that we can prevent somewhere the development of Alzheimer's dementia?
Absolutely, absolutely.
What is that prevention?
Prevention, like you said, the good lifestyle, walking, and then taking care of your overall health, like blood pressure, diabetes, cholesterol, not being obese, and having a very healthy diet, and like a fish, vegetables. It has been seen that, and green tea, like antioxidants, organic vegetables, have shown to delay the, unless it's a genetic one, or delay or prevent Alzheimer's disease. Even though we are saying that. And walking, definitely. 1 hour walking every day.
That walking called brisk walking. That's
yes, even if it's not brisk walking, even if half an hour a day, I don't push my patients to walk 1 hour a day. 30 to 40 minutes is fine. It doesn't need to be brisk walking. Nowadays they say just normal walking for 30 to 40 minutes. It will prevent everything, including medical problems, high blood pressure, cholesterol, diabetes, fatty liver, and here the non-medical like dementia. one more question for Lord.
Have you announced the next speaker?
Right, I think she has.
Oh, sorry.
Just one question.
What then? If your mom died from Lewy body, so what are your odds of getting it, and at what average?
Yeah, it's a very good question. Still not. It's still not like a proof that it's a genetic one. Actually, this question was asked by my sister. I have a sister and a brother, and she threw a question at me that what are the odds of us getting it? So far, none.
Is there any psychiatric illnesses?
Yes, yes, it was horrible. I mean, the last part, like I said, my mom, she couldn't recognize me, and she started saying, in Bengali saying, "Apni ke?" So that really, I mean, my mom, I have to tell you who she was. She was the chairman of Department of Physics. Both my parents are physicists. She was chairman in 1982. She was an extremely brilliant lady, and she stood in every, like matric, intermediate, everything. But she lost her mind when she developed that. So it was very painful and sad for me to look. And I'm a neurologist, I can do not much. She developed the Parkinson's, rigidity and everything, and she kind of started losing her mind.
At what age of onset and when was it?
She passed away at 82, so she developed at the age, 6 years before that. She came to America actually. So I think she understood something is going on. In 2004, last she visited me in 2008, and she passed away in 2014. In 2008, when she came in here, she kept falling. That's the other tip. Parkinson's disease patients should not fall. If they keep falling, and if they are rigid completely, and Sinemet is not working, and their symptoms are symmetrical, start thinking of something else. Thank you very much. Thank you.
Common disease, the Alzheimer's disease and the dementia, and also with the personal touch of your mom being afflicted with it. We sympathize and we pray for her. And now I will be inviting our next speaker, Dr. Mujibur Rahman. Dr. Mujibur Rahman is the Associate Professor of Medicine. He is also the Associate Director of Critical Care. He is also the Director of Sleep Medicine at Brookdale University Hospital Medical Center, New York. Today, his topic of discussion will be overview of lung cancer.
Thank you, BMNA convention organizer, to allow me to present lung cancer. I'm Dr. Mujibur Rahman. I'm a lung specialist, also sleep and critical care and geriatric medicine. Thank you. So today's my topic is lung cancer. And with EBUS we can reach those and we can go for a biopsy of those nodes. So we can also have a rapid on-site evaluation. So you can get a quick cytopathology test, and that can determine whether this possibility of cancer is there or not. Now another thing came out recently is called electromagnetic navigation bronchoscopy. Some of the institutions have this thing, and you can. This allows you to have an accurate navigation to the peripheral lung lesion, which uses GPS technology. You can go in and get a small cut from there with a needle, a small amount of tissue, and that can be a process for the diagnosis. So this is a machine for nuclear biopsy needle that you can see. It just takes you to the peripheral nodule with a GPS kind of mechanism, and then you can obtain a needle core biopsy from there. So nowadays came a new thing called robotic bronchoscopy, which is last year people started using in few institutions in this country. And this is a machine for robotic bronchoscopy. These are the robotic bronchoscopy machines that you use, and this is a bats where you can also do a diagnosis by getting some tissue from the lung. These are done by the chest surgeon, and nowadays they came up with a robotic VATS system also, which is already started in use, where you can get tissue from the lung by robotic resection. So lung cancer is logically categorized in non-small cell and small cell. And in non-small cell, we have adenocarcinoma, which is 40% of the time, squamous cell carcinoma 25%, large cell carcinoma 15%, and then other lung cancer 20%. 95% of all lung cancers are classified on the basis of histology. As a small cell lung cancer 50% and non-small cell lung cancer around 85%. The small cell lung cancer is highly aggressive and almost always occurs in smokers. It is rapidly growing and roughly 80% of the patients have metastatic disease at the time of diagnosis. So most of the time, small cell, by the time we diagnose, is already metastasized, mostly in the brain. The clinical behavior of non-small cell lung cancer is more variable and depends on histologic type. About 40% of the patient will have metastatic disease outside the chest at the time of diagnosis. Oncogenic driver mutation have been identified primarily in adenocarcinoma, and attempts are being made to identify similar mutation in squamous cell carcinoma. Other cell types comprise approximately 5% of the malignancy arising in the lung. This distinction is essential for staging, treatment, and prognosis. So, small cell lung cancer, these are the histologic slide of small cell lung cancer, where you have the small cells, fine chromatin pattern, abundant mitosis, scan cytoplasm tends to smudge on microscopy, and synaptophysin and chromatogranin. Pathology of non-small cell carcinoma, you have around adenocarcinoma 45%, and these are the histologic picture of adenocarcinoma. Squamous carcinoma 30%, large cell carcinoma 10%, adenosquamous carcinoma 5%, sarcomoid cancer 2%, and large cell neuroendocrine cancer around 2%. So these are the histologic slides to differentiate between these cancers.
Hello.
So initial evaluation and staging, we do PET or integrated PET CT from neck to pelvis, and bone scan to stage the cancer. MRI of chest can be done. Biopsy of questionable nodes. If PET is indeterminate, then we have to go to look for the nodes and get a biopsy from there. And we usually do head CT or brain MRI to stage the lung cancer. Stage 1 is tumor that less than 3 centimeters. There is no metastasis, that we call stage 1, which is incidentally sometimes we find, but most of the time very rare to find stage 1. Stage 2 tumor less than 6 centimeters, single metastasis are observed in the same side of the lung. Stage 3 tumor more than 6 centimeters, metastasis in the lymph node, that's a stage 3. 4 is the tumor passed to other side of the body. So lung cancer, non-small cell is staged stage 1, 2, and 3, and 4, and the small cell is basically limited and extensive. The small cell lung cancer is less than 1/3 of the patient, one hemithorax that can be encompassed within one tolerable radiation therapy port, unless there is a pleural or pericardial effusion, extensive, or outside a single hemithorax. Presence of malignant cell detected in the pleural or pericardial effusion. These are all advanced small cell lung cancer. Non-small cell lung cancer, we just talked about that. Non-small cell lung cancer outcome, treatment outcome is usually, if it's a stage 1, Surgery, 5-year survival is 60 to 70%. If it's stage 2, still local surgery, adjuvant chemotherapy, 5-year survival rate is 30 to 50%. It's a 3A/B. If it's regional chemoradiation, 5-year survival is 20 to 30%. But once it's stage 4, only chemotherapy, and 5-year survival is less than 5%. So usually the lung cancer is a multidisciplinary approach. Pulmonologists, CT surgery, oncologists, radiation oncologists, nutritionists, social worker, and palliative care team, they all work together for a patient that is diagnosed with lung cancer. Treatment of lung cancer varies depending on the cell type and the stage. Surgery, chemotherapy, radiation therapy, immunotherapy is the mainstay of treatment. Many patient factors not related to the tumor affect treatment choice, especially the poor cardiopulmonary reserve. If somebody has a severe emphysema cardiac disease, treatment plan can be different. Poor nutrition is another significant factor about making decision about the treatment. Frailty or poor physical performance status is a major factor in other comorbidities, including cytopenias and psychiatric or cognitive illness. It also affects the plan of treatment. Surgery, you can have a wedge resection. The first picture you can see on the top, and if it's a small nodule, you can take it as a wedge resection, or you can do a segmental resection. You can take a bigger piece of the lung and can be taken out surgically, or you can take the whole lobe out, which we call lobectomy, and or the whole lung, the right or left lung, when we call it pneumonectomy. So, depending on the size of the mass and the involvement, surgery can be done in these different 4 different ways. There are many chemotherapeutic drugs. I'm not gonna go there. I don't have much time left. Mass, and you can use a radiation therapy to reduce the volume, and sometimes treat that cancer, but I rarely have seen radiation really cure anybody. There are some immunotherapy came out recently, so these are the different immunotherapy that can be used for lung cancer. Regarding lung cancer, if chemotherapy second line and palliative chemotherapy fails, you can also use as a palliation different stenting depending on where the effect of the lung cancer is. If somebody's air passage is blocked, then you can, as a palliation, can use all different sort of stenting for the airway. Complication, usually you can have pleural effusion, you can have refractory pleural effusion, which is difficult to treat, where a patient may go home with a Purex catheter and can drain those fluid out again and again. Sometimes we do, if somebody has a recurrent pleural effusion, we can go for a pleurodiosis, which is chest tube or a VATS. Corticosteroids are commonly used, but really don't help much with the pleural effusion. Prognosis for small cell lung cancer, overall prognosis is poor. The median survival time of limited stage small cell lung cancer is 20 months, with a 5-year survival less than 20%. Patients with extensive stage small cell lung cancer especially do very poorly. Their 5-year survival rate is less than 1%. So small cell lung cancer is the most devastating lung cancer. Now, the small cell lung cancer varies on the type, the stage, and the tumor marker, and there are nowadays many more medicine came out, and survivability is much better than what used to be in the past. End of life care is very important based on poor overall survival. The need of end of life care should be anticipated. Early palliative care intervention lead to less end of life chemotherapy use and may even extend life. Symptoms of breathlessness can be treated with a supplemental oxygen and bronchodilator. Pre-terminal breathlessness can be treated with the opioids. The care provided by the hospice program is extremely well accepted by patient and family. yet this intervention is markedly underused. So end-of-life care determinations and discussion with the patient and the family is very, very important to guide the patient and the family for appropriate treatment and management. Empathy is very important in patient-physician communication and is associated with improved patient satisfaction and adherence to physician recommendation. These are different studies showing that important empathy is with the communication with the patient and family is important. Prevention, no active intervention to prevent lung cancer except for smoking cessation. Remediation of high radon level in private residence removes known cancer from radiation, but a reduction in lung cancer is unproven. Increasing dietary intake of fruits and vegetables high in retinoids and beta-carotene appears to have no effect on lung cancer incidence, so taking those vitamins may not help. Vitamin supplement is either unproven like vitamin D or harmful like beta-carotene in smokers. So patients that smoke cigarette, please avoid vitamin A on them. There is a study showing that it increases the lung cancer. Evidence suggests that non-steroidal and vitamin E supplementation may protect former smoker from lung cancer has not been confirmed yet. Molecular approach targeting cell signaling and cell cycle pathways and tumor-associated antigens like precision chemoprevention are under investigation. So there's not much prevention except to stop smoking. What is the future? Lung cancer screening, some combination of molecular analysis of genetic marker may help in future. Sputum cytometry, detection of cancer-related volatile organic compound in exhale breath, and studies now have been shown that trained dog can discriminate lung cancer patient with a control based on exhale gas samples. So maybe one of these days we're going to use dog to diagnose lung cancer early. Take-home message, the main factor contributing to lung cancer is smoking. About 50% of all lung cancer patients have never smoked cigarette and have suspected driver mutations. Still, non-smoking patient can have lung cancer, most commonly adenocarcinoma in them. Lung cancer can be small cell lung cancer or non-small cell lung cancer. Several genetic driver mutations that are amenable to targeted drugs have been identified in non-small cell lung cancer. Manifestation can include cough, fever, hoarseness, pleural effusion, pneumonia, Pantos tumor, paraneoplastic syndrome, superior varicose syndrome, Horner syndrome, and metastasis to the brain, liver, and bone. Suspect the diagnosis based on clinical information and imaging studies like CT, PET CT, cytology of sputum and pleural fluid and core biopsy. Consider yearly screening of low-dose helical CT for current or former smoker who are more than 55 years at a high risk. Shared decision making should occur before imaging is pursued. Do testing beginning with the whole body imaging to stage cancer. Treat early stage non-small cell lung cancer with resection when pulmonary reserve is adequate, often followed by chemotherapy. Treat advanced stage small cell lung cancer, non-small cell lung cancer with chemotherapy and immunotherapy. Genetic testing should be completed on adenocarcinoma to help define treatment regimen. Because as I mentioned earlier, the new medicine came out which is quite effective for adenocarcinoma. Thank you.
Majumdar, he is our mentor. And I don't know what to say about Dr. Mujibur Rahman Majumdar. The topic was really excellent and it was very informative. Now it's my pleasure to ask Dr. Muhammad Hamiduzzaman. He's a medical director, critical care medicine. Today he is going to discuss on nutrition management in critically ill patients. Please welcome Dr. Zaman.
This lecture will hopefully reinforce what we are practicing, and at least we'll keep it at par. Now, first of all, there's an alteration in your substrate utilization between starvation and critical illness.
We can't see anything. Hello?
Yes.
Somebody can hear us?
Yes, you cannot share. Let's see how to share. It should go on already. It should go right. Sharing screen. But okay. I did it. The month of the title. Glycogen stores, and the body immediately moves to fat metabolism, so we have the ketogenesis. And from then on, as we are starving, the body does everything to maintain the lean body mass. So protein is protected. That's normal physiology. So much here. On this last year. Catabolic stage. And body can ramp up to glycogenosis as usual, we have hyperglycemia, and from then on it jumps to protein utilization. And in critical illness, the body, all it does is to limit the fat metabolism. So here in the hypercatabolic state, and this has been called the total caloric death of critical illness. So you have hyperglycemia, then you have protein breakdown of the gut and the muscles, and the fat is not absorbed. And this goes on in all phases of critical illness that we call it acute or late acute and post-acute phases. And this caloric debt or proteolysis goes on all along throughout the illnesses. And in the gut, there is a dysfunction of what is called dysbiosis. That's why the importance of early gut feeding comes. If you can prevent this dysbiosis of the gut, the infection incidence goes down significantly. Now this this nutrition support is very important in critical illness because in all stages you are having proteolysis. So as you go over my talk, you'll find that you have to supplement high protein intakes on these patients. Now there are 4 societies that has issued guidelines for nutrition. Today I'll talk on the American Society of Parenteral Nutrition and Society of Critical Care Medicine, but the European Society of Parenteral and Mental and Enteral Nutrition and the Canadian Clinical Guidelines Society have also all given the guidelines of nutrition support and critical illness, and the basic concept is all 4 guidelines are the same. So that's the express consensus is that whenever you see critical illness patients or any patient in the hospital, you first assess the nutritional risk of the patient, and that will identify a group of patients who will benefit from your nutritional support. Now, there are 2 scores that not normally give. It's called the nutritional risk score, and the other one the nutritional risk in critical illness score, Nutri score. And these guidelines are available on all the apps we can use now in our smartphones. Basically, the Nutri score in the ICU takes all the parameters that you follow in the ICU, the age of the patient, the Apache score of the patient, the SOFA score, number of comorbidities, and days from the hospital to the ICU, how many days is required for the patient to come to the ICU. And some ICUs where you measure the interleukin-6, you also has a point for that. But most ICUs are not going to use the interleukin-6 as a costly test, not widely available. So most of the time you will use the Apache, SOFA, comorbidities, and the hospital to ICU admission. And that gives a number between 6 to 10 is the highest score. If the patient's Nutri score is more than 5, you have a patient who is at high risk of nutrition decompensation, and this patient will benefit from nutritional support. If the score is less than 5, probably in the first week of critical illness, you do not have to give a special nutrition for the support of this patient. Those who don't use the nutrition score, we are going to use the NRS, the Nutrition Risk Score 2002, and this is very simple. You ask few basic questions. What's the BMI of the patient? Has the patient lost weight in the last 3 months? Has the patient reduced dietary intake by 25 to 50% in the last 2 weeks? And is the patient severely ill, okay, going to the ICU? So if any one of the answers is yes, which most of the patients that in our hospital are, then you go to the next phase. Then you take this scores of weight loss of more than 5%, food intake is decreased by 250 to 75%, and other one is what's the BMI of the patient. So you give this 1 and 2 numbers, and if the Nutri score is more than 3, this identifies equivalent number of patients of the Nutri 5, that these are high-risk nutritional patients. So that's all it tells you that these are the patients that we have to figure out that they will, these high-risk patients should give a special consideration for nutritional supplementation in the ICUs. The expert consensus also says that you also ask for the risk factors for these patients. Okay, what is this function of the gastrointestinal tract? Does the patient have comorbidities? And do not use the traditional ways of measuring nutritional susceptibility by pre-albumin and some blood test will do. That's not recommended by the expert consensus. How to figure out the calorie requirement of the critically ill patients? Now the standard of care has been indirect calorimetry, which is not available widely, except in the burn units or specialized ICUs. So if the indirect calorimetry is available, then use the indirect calorimetry to determine the calorie need of this patient. In the absence of indirect calorimetry, there are some simple equations that we use, and the easiest one is to use 25 to 30 kilocalories per kg per day of the ideal body weight, not the actual body weight, but the ideal body weight of the patient. So that's the 25 to 30 kilocalories per kg per day. And at the same time, you should do adequacy of protein provision. As I told you earlier, that this is a proteolytic process. Body is using all proteins, so given special attention to the protein provision for this patient. Most important part is that when you start initiation of the nutritional support. And the guidelines clearly says that you start enteral nutrition within 24 to 48 hours. And you go to your goal of 100% of the caloric needs or more than 80% of the caloric needs by 72 hours. So if I needed a patient on high nutrition risk, you should initiate therapy as soon, nutritional support as soon as possible, like after admission. And this is the benefit of early enteral nutrition. As I talked about earlier, about the dysbiosis of the gut. If you can prevent the dysbiosis of the gut, there's a decreased incidence of infection, in secondary infection in the critically ill patients. That's why the importance of early nutrition comes. What is the route of nutritional support? Always the enteral route is preferred, so over the parenteral route. So if you can use the gut somehow, or if there is an intolerance of the gut feeding, give some prokinetic and use the enteral nutrition all the time in the critically ill patients. What are the other signs of contractility? So most of the time we have to assess about the gut contractility, but do not concentrate on listening to the bowel sounds. If there is no obvious bowel obstruction, then start feeding and don't make a decision just on physical exam of the absence or presence of guts, bowel sounds or patient passing the flatus. Start feeding and see what happens to these patients. Site of infusion, always we have these fancy tubes in the ICU. Only the distal feeding tube, like you put your feeding tube in the duodenum or post-pyloric area in the people who are at risk of aspiration. Not everybody needs post-pyloric feeding. And these are the guidelines. If you, patients who are at higher risk of aspiration, if you start a post-pyloric feeding, the incidence of infection goes down. And these are data is pretty widespread, starting from 1990 to 2002 and 2012. That is data. So this is pretty good meta-analysis. Yes, the patients who are at high risk of aspiration, post-pyloric feeding benefits those patients. But the expert consensus there, and in our practice you see all the time, most critically ill patients, most patients tolerate enteral nutrition in the bite from the stomach. So put a regular feeding tube, don't waste your time to go to post-pyloric area and start feeding. What do you do in the shock? Now this is very important. When the patient just comes to the emergency with hemodynamic instability, until the patient is resuscitated fully, do not start feeding. Okay, so first few hours of resuscitation or shock, hold your enteral feeding. The risk of ischemic bowel goes down at that time. What about the nutrition in the first week? Okay, so patients who cannot maintain pollution in their low rich nutrition, like your Nutric score is less than 5, NRS 200 score is less than 3. These patients for the first week does not need a special nutritional support. They can just kept whatever feeding they are tolerating. Okay, but in the patients who are ARDS or acute lung injury, now you can do, there are two controversies that you should not feed this patient, like give hypocaloric feeding or full feeding. till both modes. You could go get your 80% of the nutrition need in the first 72 hours, or you give it a hypocaloric diet, less than the requirement, like 20 ml per kg or 200, 500 ml of fluid for the NG2 feedings. Both of them have similar outcomes, so no need to concentrate by doing a hypocaloric diet or full caloric diet. Nutrition in high-risk patients. Those patients who are severely ill, like in NRS score of more than 5, Nutrica score more than 5, or NRS 2000 score more than 3, they should be started feeding as soon as possible, 24 to 48 hours after admission to the hospital or to the ICU. And when you start feeding, your goal is to get to this 80% of the calorie need. Remember that we decided about 25 to 30 kilocalories per kg of our body weight. Then we should achieve our goal within 48 to 72 hours to get the benefit of early nutrition. That's why the importance of it comes to not to hold the feedings on these patients for procedures all the time. Next conscious is that we must pay attention to adequate protein intake on these critically ill patients. The protein requirement is 1.2 gram per kg of actual body weight. Now this is higher in people with a multi-trauma patient or burn. They might require 2.5 up to 2.5 gram per kg of actual body of protein. So protein supplement is very important in enteral supplement of these patients in the ICU. Whatever the duration of feeding per day is, if duration of feeding is not connected to your calorie goal. Basically, if you need 25 ml per kg per day, you should not hold feedings. Okay, so now we still had a practice of start feeding and then feed for 18 hours and 6 hours rest to the gut. So that's not recommended anymore, because most of the time your patients will be in you for some test or the nurse will not have enough function of the feeding tube. That's why it is recommended do not put unnecessary NPU, no food for what the NPU status. So continue feeding. So now the standard of care is we write the order for feed for 24 hours with the assumption that patients will not get 24 hours feeding, so that you can get your calorie needs by the 48 to 72 hours after admission. Very important, the misnomer gastric residual volume in the most ICUs. Actually, at least in the older days when you practice, the nurses routinely measure the gastric residual in the morning, and they will hold the feeding with it arbitrary number. This is not recommended. There is no need to routinely measure gastric residual in the ICU. If the protocol in the ICU is still there that you should measure the residual, do not hold feeding below 500 ml of gastric residual. So there is no need for doing residual measurement every day in the morning. Always some feeding protocol, started feeding protocol in the ICU, so that how many 10 ml per hour you're increasing the feeding, or 20 ml, whatever the policy of the ICU is. Some protocol always helps you to get to your goal of 80% of nutrition, calorie needs by 24 to 72 hours. Always design a protocol, whatever protocol you like. So, but has a nutrition team work with the critical care team to that, and the literature review actually has a strong evidence for attaching to it for a feeding protocol to get to your nutrition goal in the first 72 hours. And these are basically these studies. Now, when you had a protocol, you achieved your goal and your infection rate was much less when you had a feeding protocol in the ICU. Now, always make an assessment of the aspiration risk of the patient. Actually, every ICU patient, the nursing department, nursing and the clinical care team should have assessed the patient for proactively whose patient is at aspiration risk and what are the precautions we should take. The evidence for this is pretty high, moderate and high. So always assess the patient for aspiration risk and guidelines about it. How about prokinetics for enteral equation? So for patients who are at high risk of aspiration, you can use the prokinetics like erythromycin or metoclopramide. Keeping in guideline, the metoclopramide has pretty adverse effects about those things, but erythromycin works pretty good as a prokinetic in the ICU. And what are the best measures that can prevent aspiration. Actually, simple things like keep the bed of the patient up at 30 to 45 degrees. When you enter your ICU, you see the bed most of the time is flat because nurses are doing some nursing issues. Insist on that. Keep the bed up at 30 to 45 minutes. And simple mouthwash technique. And this study we published for our institution is quoted widely in the literature. Just simple mouthwash, like with chlorhexidine twice a day, decrease our VAP rate to almost zero from a national high. So this is pretty effective. Mouthwash and keeping the bed of the bed elevated for 30 to 45 minutes. Checking for aspiration, do not use the special dyes like the blue dyes or the glucose oxidase that provide the patient aspiration. That should not be employed routinely in the ICU. Feeding forward for diarrhea. It is recommended that do not hold feeding when the patient has diarrhea. Rather work up the cause of diarrhea and continue feeding as much as can. Because the importance of caloric intake and the protein intake is so important to get the benefit of nutrition in these critically ill patients. Now, standard polymeric formula is pretty good enough, so you don't have to go to special formulas that we used to use in the 1980s all the time. The simple polymeric formula that we have available in the hospital is good enough for all the ICU, for the ICU patient. But in surgical ICU patient, there may be some benefit of the disease-specific formula. 6, or the patient is severely malnourished, it is very important that you can use parenteral nutrition in the first week also. Now this comes to this COVID-19, like the Society of Critical Care presented a guideline for the nutritional support in the critically COVID-19 patients, and these are the group of patients who are severely malnourished as proteolysis. You can consider parenteral nutrition in the first week of patients with the COVID-19 critical patients. Supplemental parenteral nutrition, like you said, okay, my patient is 2000 calories, my enteral nutrition is giving only 1000, should I use parenteral supplement nutrition to this patient? Now, it is not recommended in the first 7 to 10 days. So, for 7 to 10 days, continue gut feeling, when you add the parenteral nutrition, you consider after the first week as a supplemental nutrition. Protocols always helps. You must have a protocol in the ICU particularly for parenteral nutrition, otherwise you will end up with a lot of complications. When you're giving a TPN, you must have a dedicated central line. That central line should not be used for anything. You have these triple lumen catheters, do not use TPN with triple lumen catheters. You will end up with more infectious complications. So the protocol and nutrition keep following this patient is always beneficial, or rather actually should be mandatory when you're giving parenteral nutrition in the ICU. How about parenteral nutrition in the first week? Okay, so patients who are severely malnourished or high risk, you can give parenteral nutrition first week, but do not give the whole calorie. Okay, but maximum is 20 calories per kg per day. So this hypocaloric parenteral nutrition is okay in high risk patient and in malnourished patient, but you always look for the refeeding syndromes. Get your electrolytes and phosphorus, magnesium every day, so that you don't have the refeeding syndrome on these patients. Fat emulsion should be avoided in the first week, particularly soybean-based fat emulsion that's available in most US hospitals. So do not use it, but the alternatives for fat emulsion that are available widely in Europe now, they can be used if you want to use it. So for the first week, avoid fat emulsion in parenteral nutrition. And this is the literature of the benefits of the harmful effects of soybean fat emulsion using in the first week. If you do not use fat emulsion in the first week, your infectious contributions are less. Now, be aware the propofol that you use in the ICU all the time, that gives a lot of fat emulsion. So if you're using propofol on this patient, take into consideration the caloric supplement that you're getting from the propofol. But first 1 week, do not use fat emulsions. How about getting a commercial formula from outside and you having your own compounding in parenteral nutrition? There's no difference. So if it's easier for your hospital to contract the company that will give the parenteral formulations, you can use it, or your pharmacy can definitely compound the for parenteral nutrition every day. Control of glycemia, this is very important. The initial study came only in the cardiovascular surgery patient. Very tight control of sugar between 80 to 110 gives a mortality benefit, but it does not apply to medical and ICU patients. As a special surgical patient, you probably still have the benefits of tight control, but medical ICU, the benefits of the hypoglycemia was very bad. Actually, the mortality was almost directly related, proportionally related to the mortality of hypoglycemia, severe hypoglycemia. So now the guideline is 140 to 180 to keep the blood sugar between 140 to 180 on critical ill patient. Either using insulin drip or you're sliding a scale, but not the tight control of 110. You have more hypoglycemic events, and that does risk to increase mortality. Parenteral glutramine, as I discussed before, although it has some benefits in the randomized trial, is not routinely recommended in a parenteral nutrition in the ICU. Now, how about discontinued parenteral nutrition? The side effects of parenteral nutrition are so much that you must always try to taper down the parenteral nutrition. So, as you always try to increase your enteral nutrition, and once you go to the enteral nutrition of 60%, you can discontinue your parenteral nutrition. Now we used to do this before initially, but it's recommended that do not alter your formula parenteral nutrition to get a respiratory quotient of 0.8. Thus it's not recommended anymore, but the evidence of the literature is very low. How about fluid restriction? The guideline is still stated. If a patient has acute lung injury, ARDS, respiratory failure, you want to keep this patient dry. So decrease the fluid intake as much as you can in this patient with acute lung injury or ARDS. Phosphate monitoring is very important because, as I said, in severely malnourished patient or high-risk patient who start feeding, you might develop the feeding syndrome. So it is routine that you is with phosphate monitoring daily in the ICU. What about the acute renal failure patient? Most of the critical ill patients develop AKI or the acute renal failure in the ICU patient. Important is that do not decrease your protein recommendation. It's 1.2 to 2 grams per kg per actual body weight. There's no benefit that if you cut down the protein intake, your progression to renal failure benefits. So no need to restrict protein in the AKI patients or renal failure patients. Then the opposite happens. When you start this patient on CRRT or CVVHD or a hemodialysis in the ICU, the protein intake should increase to 2.5 grams per kg per day because you lose a lot of protein from the dialysis membrane. Cirrhosis and hepatic failure patients, do not take the total body weight, go back to the ideal body weight calculating the energy intake, and then you do not need this protein restriction in liver failure patients. Okay, so do not restrict your protein. Do not restrict the protein that, okay, my patient will not develop hepatic encephalopathy if you have no protein. Protein intake in these critically ill patients remain the same, 1.2 to 2 grams per kg. Always enteral nutrition is beneficial. We cannot overemphasize throughout my talk, and the guideline, the enteral nutrition is the way to go, particularly liver cirrhosis patients. Try all your means to increase the tolerance to the patients, okay? Now, there's no evidence that if you give branched-chain amino acid or formulas for patients who are already hepatic encephalopathy, as long as you're treating them with gut antibiotics. So no need for special formulas for cirrhotic or liver failure patients. Acute pancreatitis, this is the most looked into nutritional supplement for this patient. In pancreatitis, you have to look into severity of the pancreatitis. So these are all the guidelines that you have and clinical impression whether this is a mild pancreatitis, then there is no special need for nutritional supplement for this patient. But this patient's severity of illness can change. Always assess the severity of illness from day to day. As soon as they become a moderate to severe pancreatitis, this patient needs a special nutritional supplement, particularly in the enteral feedings. Moderate to severe pancreatic patient, always start feeding within 24 to 48 hours by the orogastric or nasogastric tubes. Now, there is no need to put a Duval tube or a Duval tube on this patient. Most of these patients will tolerate a gastric feeding by a feeding tube in the stomach. So what the important thing is that in pancreatitis to start feeding as soon as possible. The standard polymeric formula is as good, special formulas are not needed for patients with severe acute pancreatitis. This is the latest data came out that stopped the parenteral nutrition acute pancreatitis. That definitely shows that if you feed this patient post-pyloric, your mortality benefit is much higher than if you use parenteral nutrition. So this got published in the New England Journal. After that, parenteral nutrition was died in using factor pancreatitis. So try to use your enteral nutrition as much as you can in patients with pancreatitis. Start your feeding with a orogastric tube and if the patient has residual, then you can put on a jejunal tube. But start feeding as soon as possible. Now, all patients with severe pancreatitis, okay, should all you try to do increase your tolerance of the gut feeding. So you can use erythromycin again, you can use metoclopramide again, increase the gut mortality. If they don't tolerate feeding by the gastric placement of the feeding, then try to put a jejunal tube. The probiotics can be considered in patients with acute pancreatitis. So but always use the probiotics which have randomized control trial, not the random probiotics that are available in the market. In acute pancreatitis, if you have to use the parenteral nutrition, let the 1 week go by. Second week, start parenteral nutrition. Okay, after 1 week of onset of the acute pancreatitis. Now, surgical patients exactly the same, protein intake is the same, except the 20 or 40 hours injury. You should start feeding within 20 or 48 hours. And traumatic brain injury patients and multiple trauma patients, you can consider some specialist formulas. Immune modulating formulas can be used in the patients with severe trauma, as I told you before. And immediate important thing is that all trauma patients, the feeding must be started within 20, 40, 48 hours. Even the patient has an open abdominal wound, if the gut can be used, you must start feeding as soon as possible. Traumatic brain injury is a special situation, you can use arginine-containing immune modulators. There is some data, there is some mortality benefit on these patients and infection complications. As I told you before, you have open abdomen, use the gut as much as you can. But important thing in open abdomen is that you lose a lot of protein from the peritoneal fluid. So protein should be 15 to 30 gram additional protein in addition to 2.5 gram per kg per day we said, add additional 30 grams of protein. Protein is so important in nutrition of these sick patients. Burn patient again, if you have a burn, if you can use the gut, use the gut. Okay, if the patient can, somehow you can put a feeding tube on this patient, start the feeding as soon as possible. And it should be started, now look, see, we are giving also for 24 to 48 hours. Burn patients, the enteral nutrition is so important because this patient has infectious complications. They're insisting that start feeding if you can within 4 to 6 hours of admission to your ICU. Not in the early first 6 hours, okay? If the patient, when you're being actively resuscitated, you do not have to start feeding. But once the patient is stabilized, you can up the patient with your guidelines, and the patient is on a fixed dose of pressors, you start feeding slowly within 24 to 48 hours, and look for the signs of issuing bowel. Otherwise, go to your goal of about 80% of the calories needed by 72 hours. Septic shock, basically parenteral nutrition or supplemental parenteral nutrition is not recommended in patients in the septic shock, despite their high risk or not. Get away from parenteral nutrition in septic shock patients. Trace elements is not recommended, although you use it during the COVID pandemic. We have been using everything in the world. Zinc, selenium, but we don't have data that it helps. Trophic feeding is saving the first few days, as I said, 80% target energy level. Okay, but protein is very important. 1.2 gram of protein per kg per day is suggested. Okay, so. But that, as I told you before, there is no data whether it gave trophic feeding or full feeding. The outcome of this patient is good, but when you are coming out of the septic shock first 2 days, you can give a hypocaloric feeding in the first few days. Immune modulating formulas not used routinely in patients with sepsis. Post-operative surgery, again the same thing. If you have a low-risk patient, that do not use this serum aluminum free aluminum transplant. This is a surgical ICU, go to surgical ICU, you see the surgical resident routinely ordering this test. These are not recommended as per the guidelines. Assess the nutrition risk of the patient by Nutri score or the NRS 2000. Post-operative patient, again, you should start feeding as soon as possible, 24 hours. Do not wait for the bowel sounds are present or not. If you had a good surgery, start the feeding as soon as possible. Okay. Immune modulatory formulas in the surgical patients, it has some data that you can start using them, particularly traumatic brain injury patients. If the patient has severe surgery, is coming to the ICU, start feeding as soon as possible. Should not be initiated in the first 7 days. Take-home message that parenteral nutrition in surgical patients do not start in the first week. Unless the patient is very high risk nutrition or malpractice or malnourished, it can start in the first 7 days. Post-operative diet, there's no need to start feeding with clear liquid. Actually, bite-sized foods are very tolerated for patients over other things. Chronic ill ICU patient, I said, those that in the ICU for long, for 21%, they should have always a high protein and protein in their diet. As I told you before, in the chronic illness also, the protein lytic system goes, metabolism keeps on going on. Obesity is unique. We think these are obese people, but these are basically malnourished persons. They have a sarcolemma is low. Basically, they must start feeding in 24 to 48 hours. And in addition, their caloric needs also look at the comorbidities of this patient. They have pro-inflammatory markers, they have diabetes on the top of that. So basically, there needs a composite assessment of the sarcopenia, particularly patients who have BMI is more than 450, they have always a systemic inflammatory response. So take into consideration the nutrition makes a very nice nutritional list on these patients, and you should follow that. One important thing is that you give them a hypocaloric diet, so they eat the fat but give them protein. That's what you should get. So 65 to 70% of the target energy requirement should be given to obese patients who are critically ill. So basically, obese critical patient, again, you have to give them weight-based calories, but you are giving 11 to 14 kilocalories per kg per day, in the range between 30 to 50 calories. Okay, if their BMI is more than 50, give them 20 to 25 kilocalories. If your protein should always be the 2 gram per kg of ideal body weight for the BMI of 30 to 14. So basically, on the basis of the BMI, you calculate the energy intake, but your protein supplement is the same. If your patient's BMI is 30 to 40, your protein intake is 2.5 gram per kg per ideal body weight. Okay, for patients with BMI more than 40. Protein is important for these patients. So basically, you're giving a low caloric, reduced parenteral nutrition, and then same thing, immune response of the patient with a potential benefit of immunological formula. So there is no need to do that. I should stop in the time. So the guidelines is the same. For hyperglycemia, your goal is to 140 to 180, and then you have hypercapnia. If you have hepatic fat accumulation or resolution, including enteral nutrition. So basically, follow the same thing, but keep them hypocaloric diet along with high protein intake. Now, the patients who have had bariatric surgery, very important to give supplemental thiamine to these patients because they develop cardiomyopathy. In earlier days of our bariatric surgery, we had a lot of patients with mortality related to cardiomyopathy. So supplemental thiamine is very important. It's very important to follow up with the patient. They get a prescription, but because of the post-operative stage, they cannot even keep anything on it. So make sure these patients are giving their supplemental diets. Now you are not obligated to give supplements or diet to these patients who are end of life. They're doing DNR, DNI, hospice care. It needs the art of development. It talks about family members and the very social worker service. But the guideline does not recommend that you are actually obligated. If patient is DNR, DNI, then you see order for parenteral nutrition. It basically have no benefit. So that's the guidelines are clear for this one now. I will stop here if any questions. Thank you very much for your attention.
Thank you.
Thank you. It was really helpful. It's like almost like part of our life, days of our life. Every day we're dealing with the nutrition in the hospital. Not only hospital, sometimes in the house, even in the house, like hospice patients. So very informative and so useful for us, all of us, in all specialty. Thank you so much.
Yeah.
Our Shajul Khan, thank you. On COVID, the histopathological features of the COVID. So we know the coronavirus, the SARS-CoV-2, is a zoonotic disease, causes the COVID infection, and it's continuing to spread all. It started from Wuhan, China, spread all over the world. It's still spreading and causing a devastating consequences all over the world. So the infections ranges from asymptomatic to mild, moderate, respiratory and non-respiratory symptoms to severe COVID pneumonia and ARDS with multi-organ failure. It can cause the post-COVID syndrome or long COVID. The complex clinical pictures, we know how complex it is. It's very difficult virus. Now it's a novel virus, and it damages and attack the human body in multiple directions. So it also elicits the human host response, triggers a wide ranging of immunoinflammatory, thrombotic, and parenchymal derangement. So the effects of the COVID on the nervous system. The nervous system, we are going to start from the nervous system because it's on the top of our body. So the nervous system is frequently involved in hospitalized patients with COVID, and the SARS-CoV, we know, it uses the ACE2 receptors and is also present in the brain, especially in the brain vessels, pericytes, smooth muscles in the vascular wall, choroid plexus, and neocortical neurons. So what are the manifestations? I'm just going to highlight on it. I'm not going to discuss in details on the manifestations. It can cause the ischemic stroke, and in earlier stage of the corona, we have seen a lot of young patients came with an unusual embolic stroke without having any underlying problem or comorbidities. And in the subsequent series, they reported and also we see elderly patients, they came with the stroke and with the underlying multiple vascular comorbidities or other comorbidities. And COVID related hypercoagulability, which we know that increases the susceptibility to the cerebrovascular events. Autopsy series shows widespread microthrombi and patches of the infection in some brains. It can cause the encephalopathy and the encephalitis, and it affects majority of the critically ill COVID patients, especially with the ARDS. The several COVID-19 patients meet the diagnostic criteria for infectious encephalitis. So what are they? They usually presented with the altered mental status, fever, seizure, and WBC was present in the CSF, and neuroimaging showed some focal brain abnormalities, and that goes in favor of encephalitis. And a they reported 2 cases, and they detected the COVID virus in the CSF, which is not very common, is very unusual and very uncommon. And in one COVID-19 case, they found actually a temporal lobe encephalitis in biopsy report. But a lot of the autopsy cases, they could find the virus either in the brain tissue or in the CSF. The potential routes of the brain entry. So there are several potential routes of entry for the COVID virus, but 2 accepted, proposed and also accepted as a route of entry. Number one is the olfactory route, and we know the loss of smell is very common symptoms in COVID, and is also part of the neurological manifestation. And MRI showed some increased signals in the olfactory cortex, which goes in favor of the infection. Another one is the blood-brain barrier. It's the commonest route of the entry of the virus into the brain. It crosses the blood-brain barrier, and it requires internalization and transport of the virus across the cerebral endothelium. Another thing is the hypothalamus, and they think this is the main target and the main culprit of the immune dysregulations. What are they? So potential role of the hypothalamic adrenal, hypothalamus pituitary adrenal axis in the immune system is responsible for the dysregulations in the COVID infection. The cytokine and the SARS-CoV-2 virus enter into the median eminence of the hypothalamus, lead to the activation of the autoimmune nervous system, and releases the adrenal catechin.